All right, everyone. Thank you so much for tuning in to another NCLEX review session. My name is Alexandra, and it is a blessing and a pleasure to have you all here with me. Today, we are going to continue on in Module 6, where we're going to be finishing up respiratory. So, the last subject that we spoke on was about tracheostomy. So, I made a little short cheat sheet for you guys to make sure you know the important pieces of information you need to know for NCLEX regarding tracheostomy. So let's go ahead and open up with a word of prayer and then let's get into it. Our dear Heavenly Father, Lord, thank you so much for waking us up. Father God, please bless my students. Help them to understand this material and help them to pass the NCLEX. In Jesus' name, amen. All right, guys, remember, if you can believe it, you can achieve it. So if you keep studying, if you keep trying, even you study one thing a day, you do one question a day, you're taking it one step closer to your goal. So do not give up. Do not be discouraged. All right, guys, so tracheostomy. So make sure you understand the indications. Why would somebody need a tracheostomy? So a tracheostomy is an airway. So maybe something is obstructing their mouth and they can't get air through that obstruction. So for example, tumor, swelling, burns, or even trauma. Maybe they need long-term mechanical ventilation, or they have a lot of secretions, or we need to protect their airway. So immediately after the surgery, because it's a surgical procedure for tracheostomy, immediately after a tracheostomy placement, here are your immediate post-op priorities for NCLEX. The first 24 hours are critical. So airway patency, we want to make sure that the airway is open after a patient has a tracheostomy inserted. So monitor for any obstruction with mucus, if it becomes dislodged or it starts bleeding. If it becomes dislodged, if it's less than 72 hours old, do not attempt to reinsert because you might insert it in the wrong area. So what you do is you would call for help. You cover the hole with a sterile gauze and you're going to ventilate with a bag valve mask, the ambu bag, over the mouth and nose if possible. You always keep the obturator and a spare trach tube, one the same size and one size smaller, and the ambu bag at the bedside. Here is a list of the equipment you keep at the bedside, so make sure you memorize this for NCLEX. Suctioning procedure, we watched videos on that last week, and I posted the videos for you, so you should be good with that. If you're not, please review last week's recording and the videos I posted. Then we're going to talk about complications. That's where we left off. So complications in nursing interventions. So if the tracheostomy tube gets dislodged and it's less than 72 hours old, remember, you call for help, you cover the stoma, and you ventilate over the mouth and nose. Airway obstruction. For airway obstruction, we're going to suction, okay, and encourage coughing. Subcutaneous emphysema, this is when air gets into the chest cavity and it makes like a crackling noise under the skin. For that, we notify the provider. For infection, we provide sterile care. And for bleeding, we're going to notify the provider. So make sure you study this table for NCLEX. Some priority cues for NCLEX. Remember, airway is always first. So if you have a patient that has a tracheostomy and they're having issues with their oxygen saturation, they are your priority patient. Airway is always first. Dislodgement within 72 hours is an emergency, and you know how to deal with that. Never insert a dry or contaminated inner cannula. Remember, everything that goes into the respiratory tract must be sterile. Do not use hydrogen peroxide for fresh tracheostomy sites because this will delay healing. Use suction before trach care to prevent aspiration. And you always want to monitor for accidental decannulation and hypoxia. So you can use safe air. You don't have to memorize this, but it just kind of shows you your priorities when you're taking care of a tracheostomy patient. Use suction as needed. Always monitor for airway patency. You need to fit 2 fingers under the trach tie, emergency kit nearby, assess for any complications, keep your inner cannula clean, and replace the ties one side at a time. So these are very important principles, so make sure that you review them. All right, guys, so now we're going to go to page 191 on the study guide. And so let me just put the presentation up. So first up, we're going to talk about flail chest. So let me know in the chat if you can see the picture on the screen. All right. So, okay, thank you so much. Okay, so flail chest is a consequence of some type of injury or trauma to the chest wall. And so there's going to be a flap of the ribs. It's called the flail segment that is detached. And what you have to know for NCLEX is that this flail segment is going to move in the opposite direction of what you would expect, right? So take a deep breath. So when we take a deep breath, our rib cage expands, right? Because we're breathing in and our lungs open to let the air in, but the flail segment is going to move inside, right? So when we take a deep breath in, our rib cage opens out, the flail segment is going to move in. When we breathe out, our rib cage gets smaller and goes inside, but the flail segment is going to move out. So this is what we call paradoxical breathing. So it's in your study guide on page 191. So just make sure you know what that means. Paradoxical breathing. When you see a portion of the chest moving in the opposite direction when the patient is breathing, that is an indication of flail chest. So let's go to the study guide. Okay, so flail chest, there's an injury to the chest wall causing a damaged piece that flaps in the wrong direction. And this is what we call paradoxical breathing. The chest flap moves in the opposite direction. So the symptoms, severe pain, shortness of breath, cyanosis, and diminished breath sounds. So interventions, high Fowlers to promote proper ventilation, give oxygen, pain medication, and if it's severe, they may need to be intubated and placed on mechanical ventilation. Some other things that we're going to look at when we're talking about chest trauma is first we have to know what a collapsed lung means. So we've all seen this before, an accordion. So when the accordion gets smaller, it's like collapsing, right? So that's going to help you understand what a collapsed lung is. So we have what we call a pneumothorax. A pneumothorax can happen when there's trauma to the chest wall, and it doesn't have to be like trauma per se. It can be, for example, during a procedure, the chest wall is accidentally punctured. Whatever caused it, the issue with pneumothorax is air has entered the chest cavity and it causes a lung to collapse. Remember, write this down, air should only be inside the lung. Air should only be inside the lung. When there's air outside the lung, it's going to create a pressure and it's going to squeeze. It's going to make the lung collapse. And so the issue here is this collapsed lung cannot properly ventilate. And this is going to lead to respiratory distress. So there's different types of pneumothorax. You have a closed pneumothorax, open, and tension. So closed pneumothorax, the chest cavity is closed. So somehow air has exited the lung and entered the pleural space and caused this lung to collapse. In an open pneumothorax, the chest wall is open. So this is more likely trauma, like for example, a car accident, the patient's chest hits the steering wheel and a rib broke and punctured the lung cavity. And it has caused the lung to collapse. Then we have a tension pneumothorax where air has entered the pleural space and then it has progressed so much so that the trachea begins to deviate, right? So in the first two instances, closed pneumothorax and open, the trachea has remained midline, but tension pneumothorax, the trachea deviates. So this is going to lead to severe respiratory distress. So keep in mind for pneumothorax, the worst case scenario is a tension pneumothorax. So if on the NCLEX you get a question mentioning that the trachea is no longer midline, this is an airway problem and this is the priority patient. Then there's other variations. We have pneumothorax where it's air that has entered the pleural cavity and caused the lung to collapse. We have hemothorax where blood has caused the lung to collapse. And then we have a hemopneumothorax where you have a combination of air and blood. So for all of these, chest tube. Inserting a chest tube would allow air or blood to leave the pleural cavity and would allow the lung to re-expand. Then we have pleural effusion. So remember, whenever you see the word effusion, think found fluid. FF, found fluid, or fluid fecum, right? There's a fluid somewhere where there's not supposed to be. So in this case, this is fluid or water, and it has caused the lung to collapse. So in this situation, a chest tube can also help. Then we have pulmonary edema where there's fluid inside the lung. So in this case, diuretics would help. Okay, so if you see the words pink frothy sputum on the NCLEX, this is what we call flash pulmonary edema. It is a medical emergency, and so diuretics would help this patient, and oxygenation. So this is an emergency. So make sure you are reading your study guide so that you can understand the treatments. Okay. All right. So then in your study guide, we're going to talk about asthma. So this is on the bottom of page 192. So asthma is a chronic disease that occurs when triggers lead to airway inflammation and obstruction. So in a normal individual, let's say there's dust in the air. What would happen in a normal individual maybe if there was dust in the air? What would happen if you were in the same room with me and I took a carpet and I was cleaning up, so I shook the carpet and some dust went in the air? What do you think would be a normal response to that? Do you think maybe sneezing or coughing a little bit would be a normal response? Absolutely. Yeah, like maybe just like sneezing would be a normal response, right? However, in someone with asthma, their airway overreacts to something that is normal and, like dust or pollen or cold weather. Their airway becomes triggered and it closes off. So this is what asthma is. So some triggers that can trigger an asthma attack in a patient with asthma includes allergies, pollen, dust, pet dander, mold, cockroaches, exercise, and cold weather. So make sure you memorize your triggers. In a patient with asthma, exposure to these triggers, and there are others, can lead to an asthma attack. So we want to teach our patient how to properly use medications and to avoid these triggers to reduce the chances of an asthma attack. Because can an asthma attack kill a patient? Absolutely. Okay. It's very sad and I've seen it. Okay. So assessment: restlessness, wheezing or crackles, use of accessory muscles for breathing, and tachypnea with hyperventilation. So first up, you need to know what is a peak flow meter. So this is a picture of a peak flow meter, and it is used to monitor the breathing status of asthma patients. So how do you use a peak flow meter? So this is what I want you to memorize for NCLEX. You educate the patient to exhale as quickly and forcibly as possible through the mouthpiece. You exhale. So they're going to breathe out into this. And if the peak flow meter is in the red zone or has fallen 50% below their best reading, they need to use their rescue inhaler. So if it is in the red zone, that means they don't have the proper lung capacity. Their airway is tightening up. Okay, so this is a diagram you can use. So if they're in the green zone, they are breathing well. Their airways are open. If they're in the yellow zone, they need to be using their inhalers more often. If they're in the red zone, then they need to use their rescue inhaler. Okay? So I put the step-by-step instructions of how to educate your patient on how to use the peak flow meter, but please for NCLEX memorize where it says in red here, NCLEX tip for peak flow meter, you exhale as quickly and forcibly as possible through the mouthpiece of the device, and you're going to get the peak flow reading. And if it's green, it's okay. If it's yellow, give them their rescue inhaler and they need to be using it more often. And then if it's red, they need to seek medical attention. So some medications you need to know for asthma. Okay, so you need to know what a rescue inhaler is, what a long-acting inhaler is, and what a corticosteroid inhaler is. So rescue inhalers are what we use during an asthma attack. So albuterol and levalbuterol. Long-acting inhalers are for maintenance. You do not use long-acting inhalers for an asthma attack. Long-acting inhalers can help to prevent an asthma attack, but they won't treat an asthma attack. So that's your salmeterol. And then your inhaled corticosteroids is fluticasone. So please know those medications for your NCLEX. Another tip I want to give you is if you have to give two inhaler medications, if you have to give a bronchodilator and a corticosteroid, just remember that B comes before C. So you give the bronchodilator first, then you give the corticosteroid so that the bronchodilator will open the airway so that the steroid can get in and reduce inflammation. So B comes before C. You give the bronchodilator first, then the corticosteroid. So if you had two choices between giving albuterol and butensiide, you would give albuterol first because that's a bronchodilator, then you would give butensiide. So B comes before C, A comes before B. Okay, so your rescue inhalers, these are your bronchodilators. But your rescue inhaler and your long-acting asthma inhaler, these are bronchodilators. Okay, but your rescue inhaler are what we call short-acting. Okay, so you use these in during asthma attacks, your albuterol and levoalbuterol. Your long-acting are what we call long-acting bronchodilators. You use them as maintenance. All right, so you have to know that for NCLEX. All right, guys, let's take a 5-minute break, and when we come back, we're going to do some questions on asthma. All right, guys, so question 89. A 34-year-old female with a history of asthma is admitted to the emergency department. The nurse notes that the client is dyspneic with a respiratory rate of 35 breaths per minute, nasal flaring, and use of accessory muscles. Auscultation of the lung fields reveals greatly diminished breath sounds. Based on these findings, which action should the nurse take to initiate care of the client? What would you choose if this was the NCLEX? Very, very good. Very good. So why did you not choose choice one? So why is choice one wrong? So choice one is wrong because it would be inappropriate to come back and check this patient in 10 minutes. You would not want to leave this patient alone. So basically this choice, like choice one is saying, oh, give them oxygen and then come check them again in 10 minutes. No, that's too long. This patient is in respiratory distress. They're breathing 35 breaths a minute. They're using their accessory muscles, which further tells you they're in respiratory distress. They have diminished breath sounds. So what is going on with this patient? They're having a what? This patient is having an asthma attack, right? They have a history. So read the question. 34-year-old female with a history of asthma admitted to the emergency department. She's dyspneic. Respiratory rate of 30 breaths a minute. Nasal flaring. She's using her accessory muscles. Auscultation of the lung fields reveals greatly diminished breath sounds. So why do you think her breath sounds are diminished? What do you think is going on in her airways? So her lung sounds are diminished because her airways are closing. Remember, when someone has an asthma attack, their airways are tightening up and becoming obstructed, right, with inflammation and mucus. So let me show you a picture. So here is a normal airway, right? So this is a bronchiole, and you see the bronchioles branch off and they terminate with the alveoli, the grape-like air sacs. And so this is a normal airway. It's patent, it's open, there's no obstruction, there's no inflammation. The smooth muscle is relaxed so that it can stay open, and the alveoli are only filled with air, right? This is beautiful. This is an asthma attack. So some differences. So right away we see the smooth muscle is tightened. It's choking that airway, right? So that serves as a blockage, an obstruction, because oxygen cannot get in, right? And it's reducing the size of the airways. Then we have mucus, because remember, an asthma attack is triggered by some type of trigger that causes this almost exaggeration, this exaggerative response of the airway. And then we have inflammation of the lining of the airways. Okay, so we have all of these processes that are constricting the airways, that are blocking the airways. So if you were to put a stethoscope over this patient's chest, you would hear wheezing, and also the lung sounds would probably be diminished the more the airways became constricted. So the worse the asthma attack, the more diminished the lung sounds. Eventually, you won't hear any lung sounds because that means that the airways are blocked, totally constricted. And that's why an asthma attack is a medical emergency and can kill a patient. Okay, so that's why choice one is wrong. This is an emergency. We cannot just come back and check the patient for 10 minutes. Would you ever want to leave this patient alone? No. Anytime a patient is in distress, you never leave them alone. And we want to be there with them to help them and put them on oxygen. And we need to actually treat what is going on, which is the airways are constricted, so we need to give a bronchodilator, right? And then draw blood for an ABG, that's fine, but that's not going to help the issue. Okay, it says which action should the nurse take to initiate care? So, what do we need to do first? And what we need to do first is what is going to appropriately or most effectively help the patient. And in this case, we need to help open their airways. Encourage the client to relax and breathe slowly. That is very cruel because they can't breathe. So that is why the correct option would be to administer their bronchodilator. So I have a question for you. Should we administer a short-acting bronchodilator or a long-acting bronchodilator? Very good. We would want to administer a short-acting bronchodilator. So what is an example of a short-acting bronchodilator that would help this patient? Would it be albuterol or salmeterol? Albuterol, very good. So why would we not give salmeterol? Very good. We would not give salmeterol because it wouldn't work fast enough. It's a long acting. This is an emergency, so we need a short acting. A short acting begins working right away, right? Think of it like that. So that's why we would want to give a short acting bronchodilator like albuterol. You can also give levalbuterol, but albuterol is the most popular. Okay, so question 90. And the number is not there. I don't know why. But so read question 90 and tell me what would you choose if this was the NCLEX. Very good. The correct answer for question 90 is choice 1. So a client is experiencing a severe asthma attack. So if you were to interpret those ABG results, you would see that the patient, so what ABG imbalance do you think the patient is having? Respiratory acidosis, very good. So respiratory acidosis aligns with asthma attack because remember that airway constriction and airway obstruction, oxygen cannot get in and CO2 cannot get out, and CO2 is an acid, and that's why it would cause respiratory acidosis. And so we would want to give albuterol. It's a bronchodilator and it's going to open the airways. So, a couple of things that you have to know when we're talking about giving albuterol. Okay, so where it says here, I'm going to put a heart next to it, so make sure you study this for NCLEX. So, breathing treatments like albuterol can cause an increase in heart rate, palpitations, shakiness, and increased coughing. So, albuterol is a bronchodilator, it's going to open the airways up, and a natural effect it's going to have on the heart is it's going to increase heart rate. It's also going to increase your tremors, so hands are going to shake. The patient might feel palpitations. This is normal. It will go away rather quickly. And also, just make sure you know it's going to increase coughing. So all that mucus that was stuck, so hold on. That mucus that was obstructing the airway, the bronchodilator is going to make this smooth muscle relax so the airway can open again. And as the airway opens, this mucus, they're going to cough it out. So do you want them laying flat or do you want them like in high fowlers? You want them in high fowlers. You want them in high fowlers because that promotes proper ventilation, and also because you know when you give the albuterol, they're going to cough more, so you want them sitting up already. Okay? So very important to know for NCLEX. Something else we're going to talk about is a meter dose inhaler. So these, you've seen these all the time. So these are what we call meter dose inhalers. So this is how we deliver medication to the patient into the respiratory tract, or these is one of the ways. Okay, so one moment. So this is, you have a metal canister that has the actual medication in it, a plastic holder, and a cap that covers it. So this is the mouthpiece. This is the mouthpiece where they're going to put their mouth and deliver the medication. When they press down on the canister, it's going to give it's going to squirt out some of the like a mist of the medication. This is what we call a spacer. A spacer delivers the medication from the meter dose inhaler more effectively, because the goal is to not get the medication just into the mouth. The goal is to get the medication from the canister into the airway, right? But sometimes when you give the medication just by using this alone, most of it just ends up in the mouth and not a lot of it gets inside the airway. But when they deliver the meter dose inhaler medication into the spacer will hold the medication so that they can actually breathe it in. Does that make sense? So just know that a spacer makes using a meter dose inhaler more effectively. So how do you use a meter dose inhaler? Just like the blue one by itself. You shake the meter dose inhaler, you tilt the head slightly back, you breathe out completely. Activation should be coordinated with inspiration. So you want to press down on the canister the same time as that you're taking a breath in. So as you're taking a breath in, you press. You take a deep breath in to adequately inhale the medication. You hold their breath for 10 seconds if possible, and allow adequate time, 1 to 2 minutes before the next puff. So remember, the goal of using a meter dose inhaler is to not get the medication just in the mouth. It's to actually inhale it in and get it in the airway. So that's why when you press down on the canister, that's called activating it. So you want to breathe out completely. Then as you're breathing in a full deep breath, you activate and you press down and you want to breathe it in. You want to hold your breath for 10 seconds. And then you want to allow 1 to 2 minutes before taking in another puff. If you're using a meter dose inhaler for a corticosteroid like budesonide, which is Pulmicort, which is a steroid, you want to rinse your mouth afterwards to prevent oral thrush or oral candiditis, like an oral yeast infection. So this is how you use a spacer. Okay, you attach the inhaler in. This is a dry powder inhaler. So when you put these capsules in, this white part right here, it lifts up. Like you lift it up and you can put it down over here, and you put the pill inside here. Then you put this white part back, and the patient puts their mouth here, and when the patient or you presses this button inward, it's going to pierce this capsule, and the medication is inside and the patient breathes it in. And you know they're breathing it in because it sounds like something is rattling. This is a nebulizer. This is the inhalation solution, and it comes like in foil, and you open it and you twist this top off. It's like plastic. You twist it off. You squeeze the inhalation solution in, and when you put it in here, in the bottom part of here, and when you turn the machine on, it's like it looks like smoke gonna come out, and the patient puts their mouth here and inhales it in. Okay, so those are just some different ways that we can deliver medication to the respiratory tract. So in the hospital, we don't really use meter dose inhalers, really. We would give it via nebulizer. Like, so if a patient was having an asthma attack, we wouldn't use like an inhaler on them or even a spacer really. That's like for outside, like at home use or in their daily life. In the hospital, we would give them a nebulizer treatment or respiratory therapy would. And then in the nursing home, I used to give these a lot too. Okay, so that's how we give those medications. All right, now we're going to switch gears and we're going to talk about pneumonia. So we've seen this picture before of an open airway, keeping in mind one of the most important characteristics of an open airway that is ready to perform effective gas exchange is that the alveoli are just filled with air. That's it. The only thing that should be inside your airways is air. Switch to pneumonia. The air sacs are filled with fluid and pus. Do you think this is going to get in the way of proper air exchange, gas exchange? Tell me in the chat. If we need patent airways that are just filled with air to promote proper gas exchange, do you think having pneumonia where the alveoli are filled with fluid or pus, do you think that's going to get in the way of proper gas exchange? Yes, it is going to get in the way of proper gas exchange. So oxygen cannot get in and CO2 cannot get out. So what acid base imbalance do you think that pneumonia can probably cause? Respiratory acidosis. Very good. So with pneumonia, the air sacs may fill with fluid or pus. This infection can be life-threatening to anyone, but it is particularly life-threatening to infants, children, and people over 65. Symptoms include cough with phlegm or pus, fever, chills, and difficulty breathing. So pneumonia can be community acquired or hospital acquired. So if they did not have it while they were in the hospital, or like if they didn't have it when they first got admitted and now they have pneumonia since they've been in the hospital, it's called hospital acquired. So if they had it before being admitted to the hospital, that's community acquired. So I want you to know about PPSV23 pneumococcal polysaccharide vaccine. It helps to protect from 23 types of pneumococcal bacteria, and it is normally given to patients older than age 65. Worst case scenario, pneumonia can progress to acute respiratory distress syndrome, which can be fatal. So, for NCLEX, make sure you know that the proper position if a patient has ARDS, acute respiratory distress syndrome, is prone, laying on their stomach. This will help to promote proper ventilation. All right, so now let's do some questions on pneumonia. Oh, you know what? I think there was one more question we were supposed to do on asthma, actually. And we can do like two more questions on asthma. Okay, just to kind of practice more. Okay, do question 91 and then tell me what would you choose if this was the NCLEX. All right. So only one person got 91 correct. So the correct answer for 91 is 3. So a client with acute asthma is prescribed short-term corticosteroid therapy. What is the expected outcome for the use of steroids in clients with asthma? So remember, for NCLEX, you have to know this. Steroids reduce inflammation. So only a bronchodilator would promote bronchodilation. So steroids do not promote bronchodilation in a way. Steroids have an anti-inflammatory effect. Okay, so make sure you know that. Okay, do question 88. It is a select all that apply, and then we will review it together. Question 88. All right, guys. So this is a tricky one, but believe it or not, all of them are the answer. So let's go through it. A client uses a meter dose inhaler to aid in management of asthma. Which action indicates to the nurse that the client needs further instruction regarding its use? So we're looking for something that the client is doing wrong and we have to give them more education on it, right? So what they're doing is inappropriate and it needs, instruction. So activation of the meter dose inhaler is not coordinated with inspiration. So that is inappropriate. You have to activate or press down on the canister while you're taking a breath, right? So here they're not doing that. They're not coordinating activation of the inhaler while they're taking a deep breath. So if the patient did choice one, we would need to give them more instructions, right? So that's why we chose it. Two, the client inspires rapidly when using the meter dose inhaler. Do you want to just breathe in or do you want to take a nice deep breath when you're using a meter dose inhaler? You want to take a nice deep breath, right? Because remember, the goal of using a meter dose inhaler is not to get the medication in the mouth, but to actually breathe the medication in. So if you're just taking a deep breath, you're not increasing how much medication you're getting in your respiratory tract. So you want to take a nice deep breath. The client holds their breath for 3 seconds. No, you want to hold your breath for 10 seconds. You shake the meter dose inhaler after use? No, you want to shake the meter dose inhaler before you use it. And then performing the puffs in rapid succession? No, you want to wait like 1 to 2 minutes before doing the next puff. Okay. All right. So that was that one. All right. So now let's go do some questions on pneumonia. Okay, so do question 33, then we'll review it together. Or actually, you know what? Do questions 33 to 37, and then we will do it together. So I'll give you 1, 2, 3, 4, 5. I'll give you 4 minutes. And then, so do questions 33 to 37, and then we will review it together. All right, guys, so let's do question 33. An elderly client admitted with pneumonia and dementia has attempted several times to pull out the IV and Foley catheter. The nurse obtains a prescription for bilateral soft wrist restraints. Which nursing action is most appropriate? What did you choose? Very good. The correct answer for 33 is choice 2. So why? Okay, so check this out. An elderly client admitted with pneumonia and dementia has attempted several times to pull out the IV and Foley catheter. So they're having maybe some type of altered mental status. They have dementia, but also in the elderly, pneumonia can lead to altered mental status because remember, we saw in the picture that pneumonia, the alveoli are filled with fluid or pus, and that's going to impair gas exchange. So, oxygen is going to have a difficult time getting into the bloodstream. So, that means reduce oxygen to the brain the more severe the pneumonia gets, and that can also lead to confusion. So, in the elderly, confusion can happen in patients with pneumonia. Okay, so keep that in mind. And remember, we never just jump to restraints. You have to try other things. For example, maybe a sitter. Okay, moving the patient closer to the nurse's station and a sitter and things of that nature. However, they need the IV probably to get IV antibiotics. So if they keep trying to pull it out, regardless of what we do, the healthcare provider may eventually order restraints as a last resort. And we always want to put the restraints on a part of the bed that does not move. So we should not put restraints like on the side rails because when you put the side rails up and down, it would move the patient's arm with them and it can hurt and damage the patient's arm and wrist. We don't want to perform circulation checks each shift. That's not enough. You would want to perform circulation checks every 15 minutes, every 30 minutes, okay? So having a patient on restraints is a lot of responsibility, and we have to understand that. That's also why it is a last resort because not only do we want to provide care to the patient in the least restrictive environment as possible, but also we want to keep the patient safe. And restraints can lead to circulation issues and damage. Reevaluate the need for the restraints and document weekly. No, we're doing this often, at least every 15-30 minutes, especially when we first put them on. And ensure the restraint order has been signed by the physician within 24 hours, not 72. Number 34, a 79-year-old client is admitted to the hospital with a diagnosis of bacterial pneumonia. While obtaining the client's health history, the nurse learns that the client has osteoarthritis, follows a vegetarian diet, and is very concerned with cleanliness. Which of the following would most likely be a predisposing factor for the diagnosis of pneumonia? What is the correct answer for 34? Very good. The correct answer is age. So the moment a patient is 65 or older, they are more at risk for pneumonia. 35, which of the following are significant data to gather from a client who has been diagnosed with pneumonia? Select all that apply. What are the correct answers for 35? The correct answers are 1, 3, and 5. So you want to know the quality of the breath sounds because we want to see if, as we're treating the pneumonia, are the breath sounds becoming more clear, right? So a patient with pneumonia, you will probably hear rhonchi because of the mucus. You can hear crackles too, but their lung sounds are going to sound very wet and junky. So we want to have a baseline of what it sounds like now, and then we hope to see an improvement that as they're, deep breathing and coughing and getting breathing treatments and getting antibiotics and fluids, that hopefully we are seeing an improvement in the breath sounds. Bowel sounds really have nothing to do with the care and management of pneumonia. Any occurrence of chest pain, because chest pain would indicate a worsening of the situation. Not that it would be cardiac, really. However, we would take that symptom into consideration and understanding that patients with pneumonia often feel that they have chest pain, especially because of all the coughing. Peripheral edema, pneumonia really has nothing to do with edema. And then the color of the nail beds would let us know about the oxygenation status of the patient because remember, pneumonia does impair gas exchange. 36. A client with bacterial pneumonia is started on IV antibiotics. Which of the following diagnostic tests must be completed before antibiotic therapy begins? What is the correct answer for 36? Very good. The correct answer is 2. So when you have pneumonia and the doctor wants to select the most appropriate antibiotic, they will probably order a sputum culture so they can see what is growing in the sputum, what has caused the pneumonia. So make sure you know that you always have to get a culture before you start the antibiotics. And finally, 37, when caring for the client who is receiving aminoglycoside antibiotic, the nurse should monitor which of the following laboratory values. The correct answer is serum creatinine. So always thinking of these antibiotics and understanding that aminoglycoside antibiotics can damage the kidneys. So to make sure that we're not damaging the kidneys, we often measure the serum creatinine before we give the antibiotic and throughout the therapy to make sure it's not damaging the kidneys. All right, guys, so very good. Let's take a 5-minute break, and when we come back, so you know what? It's 11:27, so let's just come back at 11:35. We'll come back at 11:35 and then we will go to COPD. Thank you. So, COPD stands for chronic obstructive pulmonary disease, and it is an airflow obstruction caused by emphysema or chronic bronchitis. Assessment of barrel chest, exertional dyspnea, wheezing, crackles, sputum production, use of accessory muscles. They are more at risk for respiratory acidosis. Their chest x ray may show hyperinflation of the lungs and also weight loss. Interventions, putting these patients in high Fowlers and leaning forward, which we call the tripod position, as we can see here, is going to help ease their breathing treatments. And it is very important to know that receiving too much oxygen can depress their need to breathe. So we don't give patients with COPD more than 2 liters per minute oxygen via nasal cannula because when they have a low O2 saturation, that is what causes them to breathe. But if we give them too much oxygen, we're going to depress their respiratory drive. Some common medications patients with COPD take include albuterol, formoterol, levoalbuterol, and salmeterol. These are bronchodilators. Okay. All right. So just making sure you know that there's no cure. And unfortunately, COPD does progress and it can become end stage COPD. Okay. And make sure you remember the tripod position. So let's do some questions on COPD. All right. So 72. The nurse reviews an ABG report for a client with COPD. Here are the results. The pH is 7.35, the PaCO2 is 62, the PaO2 is 70, and the bicarb is 34. The nurse should first. So what would you answer for 72 if this was the NCLEX? Very good. The correct answer for 72 is choice 2. So assess the vital signs. Okay. So let's do the ABGs very quickly. So a normal pH is 7.35 to 7.45. So this is normal, right? This pH. The PaCO2 is 62. A normal PaCO2 is 35 to 45. So this is too high. A normal oxygen, a normal PaO2 is 80 to 100, so this is low. And a normal bicarb is 21 to 26, so this is too high, right? So remember in Rome, if it's respiratory, the pH and the CO2 are opposite. Well, we can't tell because this is a normal. So we need to give this an up or down arrow. So remember, 7.35 is too close to being too low, right? And so that means that the pH and the PaCO2 are opposite. So this means that this is compensated. This is fully compensated respiratory acidosis. Okay, and that makes sense because we know situations like COPD, pneumonia, tuberculosis, those kind of respiratory conditions, they increase the risk for respiratory acidosis. So we want to assess the vital signs because we want to see, especially since this PaO2 is so low, we want to see what is the oxygen saturation. So that we can make a better decision on what we need to do to help this patient. 73. When developing a discharge plan to manage the care of a client with chronic obstructive pulmonary disease, the nurse should advise the client to expect to, what would you choose if this was the NCLEX for 73? So the correct answer for 73 is a 1. So make sure you know that patients with COPD do develop respiratory infections easily. They're more at risk for infections like pneumonia, and it can lead to death in them very quickly. Patients with COPD are not going to maintain their current status. This is a chronic condition that gets worse over time. Um, and they won't require less supplemental oxygen over time. No, over time, patients with COPD are going to require more supplemental oxygen because their respiratory status will get worse to the point where it can become end stage COPD. And then they're not going to show permanent improvement. There's no cure. And unfortunately, their respiratory status will get worse over time. And the last question for COPD is going to be question 75. Which of the following indicates that the client with chronic obstructive pulmonary disease who has been discharged to home understands the care plan? What would you choose for question 75 on the NCLEX? Very good. The correct answer for 75 is choice 4. So which of the following indicates that the client with COPD who has been discharged to home understands the care plan? So the client promises to do pursed lip breathing at home. The client states actions to reduce pain. Um, COPD really doesn't have anything to do with pain, really, or pain management issues. Um, And it's not really more the pursed lip breathing, it's more the tripod position would help them. And then the client will use oxygen via nasal cannula at 5 liters per minute. No, we don't want to go past 2 liters per minute. The client agrees to call the physician if dyspnea on exertion increases. Yes, because that way the healthcare provider can assess the patient, because this can mean that their respiratory status is deteriorating. Okay. All right, guys. So very good with answering the questions. So let's go back to the study guide. So next up is influenza. So we're at the bottom of page 194. Influenza is a highly contagious viral infection. So for NCLEX, make sure you know that they need to be on droplet precautions. You wear a surgical mask when you go in the room with them. And medications often used to treat influenza include antipyretics like acetaminophen or ibuprofen and antivirals like oseltamivir or Tamiflu. Page 195, pulmonary embolism. This is a blood clot in the lungs which can block blood flow to one or more lobes of the lung. It can be fatal. And pulmonary embolism is definitely a medical emergency. So assessment, make sure you know that a DVT can become a PE. A DVT is a blood clot in the leg, and it can become dislodged and become stuck in the pulmonary artery and become a pulmonary embolism. So feeling of impending doom, if you see those words on the NCLEX, that means pulmonary embolism. Also sudden shortness of breath and cyanosis. So to diagnose it, they're going to do a blood test called the D-dimer. If the D-dimer is elevated, the patient could have a PE. Not definitely. If a patient has an elevated D-dimer blood test, they could have a PE. We have to follow it up with either a CT of the chest or a VQ scan to diagnose it. Interventions, sit the patient upright, give them oxygen, notify the healthcare provider. Prepare them either for a CT of the chest or VQ scan to confirm, and anticipate that they're going to be on IV fluids and a heparin drip. Okay, so make sure you know, feeling of impending doom on NCLEX, that means pulmonary embolism. Next up is tuberculosis. Tuberculosis is caused by Mycobacterium tuberculosis. Assessment: night sweats, weight loss, poor appetite, fatigue, lethargy, low-grade fever, chills, and a persistent cough that is productive. Diagnosis. So these are not definitive diagnoses, but these can point the healthcare provider to the direction if they need to do further testing. So chest x-ray, the Mantoux skin test, or a blood test can be used to indicate that the patient might have tuberculosis. However, to definitively diagnose tuberculosis, that is only done through a sputum culture or tissue biopsy. The isolation for tuberculosis is airborne. It is very important that if a patient is diagnosed with tuberculosis, they have to take the full course of antibiotics. If they stop taking the antibiotics, it's going to make the bacteria more resistant and more difficult to treat the infection. They will usually be on the tuberculosis regimen for 12 months, and they can stop once they have 3 negative sputum cultures. So the medications that I want you to know for tuberculosis are called RIPES: rifampin, isoniazid, pyrazinamide, ethambutol, and streptomycin. Rifampin, I want you to think the R is for red-orange. Rifampin causes red-orange urine, tears, and feces, and this is harmless. Isoniazid, you have to monitor the liver enzymes. Pyrazinamide, you monitor liver enzymes. Ethambutol, you monitor for issues with the eyes. And streptomycin, you monitor for issues with the kidneys. For respiratory medications, we learned about meter dose inhalers and spacers, and we also learned about dry powder inhalers. So review that. For your bronchodilators, I put them on a table for you. So you have your short-acting, your rescue inhalers, and your long-acting maintenance. You also have theophylline. Theophylline is a bronchodilator. Make sure you know the therapeutic serum level, okay? It should be 10 to 20. Also, I have a section on your antihistamines. So that's your cetirizine, your loratadine, your diphenhydramine. Just make sure you know that antihistamines, they're very drying. So they can lead to constipation and urinary retention and also drowsiness. I have a section on your nasal decongestants. That's your oxymetazoline, your Afrin, your fluticasone, and your pseudoephedrine, which is your Sudafed. You should not use these for more than 48 hours because they can lead to tolerance. where the patient needs to keep using it. You have your expectorants, which help you cough up, your mucolytics, which thin out secretions, and your antitussives, which suppress cough. So make sure you review that. It's at the end of the study guide, and just be familiar with the names. The last topic we're going to talk about for respiratory is chest tubes. So here we have on page 199 a chest drain system. So a chest tube, you have your collection chamber. Your collection chamber or drainage chamber is what's going to collect the liquid from the pleural space. And that's also, so the chest tube is to get air and fluid out of the chest cavity, right? So I want you to know about the water seal chamber. So let me show you something. Okay, so have you ever seen this animal before? A seal, right? Sometimes they used to be like in the circuses when I was little and they would put like a ball on its nose. So this is a seal. So this is how a seal usually gets its food, okay? The seal will come up to get oxygen and it goes down to get fish, okay? Then it goes all the way down, it swims down and it gets fish and it comes back up for oxygen, okay? And it goes down to get fish and it goes back up for oxygen. And that's how it usually spends its day getting its food. So I want you to remember the seal and I want you to think of the water seal chamber of a chest tube. So just like it's normal for a seal to go up for oxygen and down for food and up for oxygen and down for food, it is normal for the water in the water seal chamber of a chest tube to go up and down with each breath the patient takes. Okay? This is what we call fluctuating, tidling, or oscillating. So it is normal for the water in the water seal chamber to go up and down with each patient breath. That is normal. So I want you to know that. However, it is not normal if the water is continuously bubbling. This can indicate an air leak. Okay? So that's what I want you to know. This is where you monitor for air leak. Okay? So, and also you can see the water seal chamber here. So it is normal for water to go up as the patient takes a breath and down. Up and down as they're breathing. Okay? It is normal. However, you don't want to see bubbling. If you see continuous bubbling, that can indicate an air leak. Okay? So that's what I want you to know for NCLEX. Okay? It is normal for the water in the water seal chamber to go up and down as the patient takes a breath. But if you see continuous bubbling, that can indicate air leak. All right? So that is it for respiratory. Give yourselves a round of applause. You made it. So I want you to take this time and study and review what we learned last week and today on respiratory. So you have last week's recording. You're going to get today's recording. Make sure you read your study guide, review the recordings, then review your notes, and then use whatever question bank you have to finish questions on respiratory. Next Friday when we meet again, we're going to do adult renal. So make sure you focus on getting a good understanding of respiratory so that you're ready to learn about renal when we come back. Thank you all so much, and please have a wonderful and amazing day. Thank you, and I will see you next week, Friday.